Thank you. Good afternoon, everyone. Dr. Langanaka already said I'm going to be talking about viability, a balancing act, more of an ethical topic, so it was really quite of a challenge to me. My presentation outline will be covering introduction, and then we're going to look at the Western Cape criteria for viability, factors that are affecting viability criteria, survival rates in the periviable infant, management approach, the ethical concerns, and then we're going to look at the recommendation and then periviability counseling. Just before I start off with the introduction, I actually remember once I was on call with a student, and we had a mother, it was a gynae call, and a mother came in with a threatening miscarriage, and she was around 12 weeks pregnant. And I said, okay, let's just see if the fetus is viable. And the student was now confused to say, but what do you mean viable? Because they always say viability is 27 weeks. So we always use that terminology in two different ways. So then we said that we decided, so we're going to say the fetus is viable, but unfortunately at an unviable gestation. So I'm sure we all know that we are looking at a viable gestation, which refers to a stage of fetal growth that ensures a reasonable chance of extrauterine survival. In developed countries, viability is considered mostly at 24 weeks, but they also even look at, from actually some countries who look at 20 weeks up to 26 weeks, they consider that as periviable because there is uncertainty as to the outcome of the fetus at that gestation. A little story that I thought to myself was actually if I was going to be on call in a private sector and someone come in at 25 weeks with maybe an inevitable delivery. If I ask my consultant who is on call, they were probably going to ask me, does she have medical aid? And if I say yes, the next question will be high or standard option. But if I was on call in the state hospital, my consultant will first of all say, did you counsel the patient? So then we are going to have a look at why actually such a scenario occurs. But literature has shown that about 0.5% of all births occur before the third trimester, and up to 2/3 of the survivors actually suffer from moderate to severe neurodevelopmental disability, and more than 40% result in infant death. So it's actually quite a very sensitive period of where you have more than 40% that are resulting in infant death. And the prognosis, obviously, studies have shown that seems to be improved with gestation. Therefore, it means that understanding these risks that are associated with the periviable deliveries is very important during parental counseling and then decision-making with regards to whether we want to fully resuscitate or whether we just want to offer support for the infant that is born around periviable gestation. There was a circular that was handed over to us actually with regards to the viability in the Western Cape, and this is what we follow at Tygerberg Hospital. I'm sure we are all familiar with it, but the overall is that viability at Tygerberg Hospital or in the Western Cape is supposed to be 27 weeks and a minimum estimated fetal weight of 800 grams. At that gestation, with that weight, we are entitled to fully resuscitate the newborn. And then there goes to say, because you don't always have 27 weeks and 800 grams, or you don't always have the same, you have 27 weeks, but then the weight is less than 800 grams. So then the intervention in this case, this is mostly with our cases where we have the pre-eclamptic mothers who are coming in with intrauterine growth restriction or placental insufficiency. It's a little bit easy because we then consult them. But then those between between 24 weeks to 26 weeks, an estimated fetal weight of more than 500 but less than 650, we offer limited care. And then that means the lowest limit of intervention is actually set at 23 weeks and 6 days, or less than 24 weeks, an estimated fetal weight of 500 grams. I was unable to get other viability in other countries, but in Namibia, they use 26 weeks and 800 grams. That's in the state hospital, in the referring hospital, but in the district, we use 28 weeks and 1,000 grams. In Kailicha as well is 28 weeks and 1,000 grams. So it's actually, we don't have a universal definition of viability. Because if I have a mother now who is at Kailicha at 27 weeks and 800 grams, at Kailicha she's non-viable, but the moment she comes to Tygerberg, she becomes viable. So the factors that are affecting viability criteria, as I already said, you probably noted from my scenario of being on call either for a private hospital or a state hospital, really come to the lack of resources. And this has to be whether in forms of infrastructures, equipment, or whether in forms of health personnel. There might not be enough doctors, there might not be enough CPAP or enough ventilators. And unfortunately, in developing countries, our units are just that overcrowded, and we just don't have enough space for all our premature babies. So you can see how expensive it is, not only for the state hospitals, but it can be expensive for country as a whole. And it's expensive as it is for the hospital and expensive for the parents who should actually be looking after premature babies. Survival rates in periviable infants. Actually, if we are to talk about the survival rate, the morally relevant question is not asking, does this fetus at this gestation survive? Or does this fetus with this weight survive? But what we should actually be asking is, what is the prognosis for fetus like this particular one? What prognosis are we looking at? So they say that the major factor in determining viability is the gestational age. But it becomes a bit of a challenge because we are still struggling to date our pregnancy accurately. So then they said, so estimated gestational age alone may actually not truly reflect the prognosis. So in addition to the gestational age, there is a tool where the National Institute of Health and Human Development developed a tool, like a calculator. They look at the factors that will actually affect the survival in addition to the gestational age, which will be the birth weight. And they said that studies have shown that female babies tend to do better than male babies. And they also look at the gestation. Is it a singleton pregnancy or is it a multiple gestation? And then we have modifiable factors that might also affect the survival. Location of the delivery. Was this baby born in the district where they actually don't have the facilities? Was this, when their mother came in, how long did it take the clinician actually to decide whether to intervene or not to intervene? And obviously, we are now looking at the administration of antenatal corticosteroids and magnesium sulfate for neuroprotection, as we all know. And the other thing is the post-care or postnatal care. When it comes to postnatal care, still we need to decide, we need to consult our pediatrician or neonatologist, what are they going to offer that baby? But that's not where it ends. We already have decided or concluded that most of these babies suffer from neurodevelopmental disabilities. What care are they going to get after that? So all these things will need to be considered. Most probably many of you have come across this data. I think it was presented. This is the data that we have, the survival rate that we have in Tygerberg compared to the Vermont-Oxford network from 1998 to 2003. As we said that with gestation, actually it gets better, but the data that I have so far, it is showing the birth weight. So you can see improvement from 500 to 600, we have 17.4%, but as we go up to 901 to 1,000 gram, actually the survival rate is 81%. And obviously they are doing much better in the developed countries or in the third world, where 501 to 600 is 45%, and as they get to a 1 gram, 1 kg neonates, the percentage is even a bit higher, 91.5%, but there's actually not much of a difference. We are doing better. And interesting enough, when I looked at this, I wasn't able to attend the presentation, but if you look at the survival of the infants whose mother suffered from preeclampsia and those who actually just had preterm labor or PPROM, the preeclampsia baby seems to be doing quite well compared to the preterm mothers or mothers who are just coming with PPROMs and who didn't have placental insufficiency or anything like that. It was quite impressive for me. Unfortunately, I was not able to attend the talk to give you more detail of the explanation around this, but it is quite interesting. So it's still to just show that, yes, we do have premature babies who are surviving well, but unfortunately, we don't have that data to say how are they doing in terms of disability. So this is a tool that the National Institute of Child Health and Human Development have developed. I think it might be more useful maybe to our colleagues in the private sector because it was developed mostly for the gestation between 22 to 25. And already, as we said, in Tygerberg, we look at 27 weeks, and 22 to 25 weeks is not viable. This is just a picture to show you what they actually ask for. They look at those factors, like they said, you should not consider gestational age on its own. You need to look at the other things, like the sex. You need to look at, is it a singleton pregnancy, and have the mother received steroids or not. That was just an example that I put in mother who was at 25 weeks with a weight of 650 gram baby, and the baby was female, and yes, it was a singleton, and yes, she received steroids. So now they give you, when you put it in, they then give you the outcome for all infants, but they say that this tool is not giving you a definite prognosis to say definitely the survival rate is 76. It's actually based on the study that they have between 22 and 20 weeks gestation, and that is just going to give you a guide of the possible outcome, but not the definite outcome. So when you come to the management approach of our peri-viable deliveries, I like this, and I quoted it as it is actually, that although critical decisions in the setting of extreme prematurity are particularly challenging and in some ways unique, every facility that cares for high-risk pregnancy should have a consensus approach to the management of extremely preterm infants that is consistently used by all providers. We have that. We have a protocol at Tygerberg Hospital. But then there's a circular that was sent out for the Western Cape. My question is always like, when you have such a circular, which is it only meant for the state hospital, or is it meant for the hospital within that area? Whether the mother is managed in the state hospital or whether the mother is managed in the private setting. Because what comes at the end of the day is, if a mother is first seen in the private sector, 25 weeks, and they offered her that, no, we can do ABC and so, and comes to a point where the mother can actually not afford ICU in the private sector. Now she must be transferred to the state factors. And then you come, and now there will be conflict of information to say, unfortunately, we cannot offer ICU, we can only do this. And then it's going to be a bit of a challenge or a bit of a problem, because that is not the promise, or that is not the hope that initially she had with her private doctor. So it's always nice to have these guidelines, but it's always nice to follow them, and it will be a great thing if we are actually to follow them in certain, let's say in Cape Town, then all doctors will go according to that circular. So we need to evaluate the risk to the pregnant woman, looking at the short and long-term health in the context of a newborn's predictive outcome. Is it for the good that we intervene? Is it for the sake of we need to weigh the risk of being pregnant or the risk of delivering that baby, whether we are going to intervene to fully resuscitate or whether we are only going to provide care? The degree to which intervention in the question is predicted to improve the outcome. And then the ethical concerns was the most challenging part of this presentation, because I could not actually come to a conclusion of understanding. But I looked at the American College of Obstetrics and Gynecology and the Society of Maternal and Fetal Medicine. They came up with actually a very good article, and they said they looked at the ethical concerns that there are certain questions that we actually need to ask ourselves. Should resuscitation and intensive care measure be initiated in the delivery room? Most likely, they mean, obviously, should we act right away or not? Are such measures ethically impermissible? Are they optional, or are they obligatory? And how much of a say should parents have in these decisions? The other thing, on what should such decisions be based? Are we basing it on the data that we have? Are we basing it on evidence-based? Like if we have data from the third world, is that what we are basing it on? Or are we basing it on our local data? And once the intensive care measures such as mechanical ventilation have been started, is it ever ethically permissible to stop it? Maybe you thought the baby was gonna make it, and then you ventilate, and then you realize actually it's not doing much better. Should I now withdraw the treatment that I have started or not? And then obviously we all know about our 4 principles of ethics. The autonomy, they say, I read where it says that autonomy actually does not apply to the fetus. But when you're dealing with a pregnant mother, you don't only deal with a pregnant mother without a fetus, or you don't deal with the fetus alone without dealing with a pregnant mother. Autonomy does apply to the mother, but they say that autonomy does not apply to the fetus. Why? Because apparently the fetus lacks actually the capacity of deciding, of having self-rule. It lacks that capacity. And then the other 3 might be actually easy for us. We need to do good, we need to do no harm, and obviously everyone has the right to equal treatment. So with all the ethical principles in consideration, there was 3 ethical management approach for resuscitative and intensive care that UpToDate has come up with. They base the management on whether the prognosis is so poor that the infant should not be made to undergo any resuscitative and intensive care measures, or the prognosis is so good that care should be provided and procedures are ethically obligatory. Or unfortunately, the prognosis is not clear and it is very difficult to determine the relative benefit and the burden of care. So in this case, the clinician actually deferred to the patient's values and preferences. And attempted resuscitation is ethically permissible, but not obligatory. So now we need to consider the benefits and risk of obstetric intervention for the anticipated or when you think that this mother might actually have a very viable delivery. They say that, or they advise that we must only intervene after discussion with the family. We must never try to intervene without discussing with the family. The risk and benefit of management option in addition to the alternative approaches should be discussed. And obviously, we should present unbiased presentation of data related to the chance of both survival, long-term neurodevelopmental impairment, and we need to discuss option of non-intervention. The other thing that they say we also need to discuss, if the mother decided they actually want to terminate the pregnancy, they say that it should also be considered, but it also differs from country to country. What are the criteria of if a mother wants to terminate the pregnancy? As I said, you can't deal with the fetus without dealing with the mother. We should always also ask ourselves, but what about the mother? What will this intervention do to the mother? Yes, we give steroids, we give magnesium sulfate. There might be little risk to the mother. Although if magnesium sulfate is not administered accurately or monitored, it might actually not be that of a little risk. When we do cesarean section for very small babies, in case where now you need to do a classical cesarean section, what about considering, is it really justified to do that Caesar? Because in the back of your mind, then we need to think, what about uterine rupture in the future? What about the morbidly adherent placenta that they might have in a subsequent pregnancy? What about the thrombosis? What about infection, even death as a complication of going through that operation, and the future reproductive risk as well? We need to have a look at all those things. What about when we do expectant management? Am I putting this mother to risk of maternal sepsis? Will she end up having a hysterectomy because of sepsis, and then she won't be able to conceive again? And if we do expectant management in the preeclamptic mothers, if they decide they want to do expectant management, is it really worth it if a mother will end up having pulmonary edema or end up having a HELLP syndrome? I think it's easy when you have a mother that you try to counsel to intervene and end a pregnancy in view of preeclampsia. Because one thing that I realized, there is a thing of where a patient turns the question to you and asks you, doctor, what would you do? If someone is coming with preeclampsia, it's easy to say, I would end the pregnancy because you are in danger. But what about someone who is coming in with an inevitable miscarriage at 26 weeks and really want to have that baby? If it was you, what would you do? I once had such a question, and then I realized actually the situation just got real and I didn't know what to say. Parents should be given a choice for palliative care or attempt to resuscitate in light of high likelihood of death and significant degree of impairment. Still, in the back of our mind, sometimes mothers, they are going for the baby, but then they don't consider what about the long-term outcome of this baby. That's why they say that for a mother to actually make a good decision, we must actually give good counseling. Short and long-term outcome or possible outcome should be discussed with the mother if they are going to make a good choice. Another quote that I took from one article was that rather than treat patient based upon algorithm organized solely by gestational age, a plan of care should be informed primarily by whether the goal is to optimize the chance of survival or minimize the likelihood of suffering. I had a case scenario that I thought I should quickly just share with you. I had a 36-year-old at 26 weeks and 2 days by early ultrasound who came in with DCD8 twins. She had a home delivery. She came to the hospital an hour later. One baby had demised already. The other one was gasping on arrival. By then, we didn't have a birth weight of the one which came in gasping. So the one that came gasping was actually paper white, and I thought, and was severely bradycardic, and I thought it was only a matter of time before this baby also dies. Talked to the mother together with the grandmother. They seemed to have understood. It was one of those red status calls, and then I think I went back to the ward, and I don't know what happened. Sister came to me and said, "Doctor, there's still a heartbeat on that baby." Then I was like, "Yeah, no, I'm away." But because in my mind, it was only a matter of time before this baby demise. Then later, I bumped into a colleague, and the colleague was like, the pediatrician were very angry. And I'm like, why? They said, why were they not called early for this baby? But the discussion with the mother was for the baby not to be resuscitated. Of course, red status labor ward is always full of surprises. I go to see the baby. The baby was so pink. I don't know what happened. From paper white to so pink, and on CPAP, and severely distressed. Now I'm wondering, did someone give chest compressions or what just happened? Now I'm walking around looking for the mother. I can't find her. It's so full. I don't know. Is she still in admission? Where is she? And then I got hold of her in the corridor. And then I talked to her again. I said, I know the baby is still breathing, but I don't want you to actually have that hope because I don't think the baby is going to do well. First of all, I considered where the baby was delivered. Secondly, this baby never got steroids. Thirdly, the baby looked, for me, was about to die, but unfortunately resuscitated or something, and I don't know what happened. I followed up later on. The baby died 3 hours later in ICU. So I'm not so sure what happened there, and I don't really want to go to it, but my question was, I then changed the scenario. What if she was 40 years old who have actually conceived by IVF and was looking forward to having this baby, and this baby came in with a bradycardia? Was I going to give the mother a chance to decide whether I should resuscitate this baby, even if I know the outcome for this baby is not good? I don't know what I would have done. I left that question blank for myself. Recommendation from the ACOG and SMF for peri-viable birth. They said that we must always transfer to a unit with expertise of managing these premature babies, even when we think that the delivery is imminent. So it's always nice to transfer a mother with the fetus in utero. Prenatal and postnatal counseling regarding the anticipated outcome, actually regarding the prognosis. And unfortunately, we as obstetricians or those who are in obstetric are the ones who come in first encounter with the mothers. We don't always have the pediatricians on board with us to counsel the mothers. We unfortunately have to be the one to do the first counseling. But it's always nice if we are all there, because then there won't be conflict on information, because if the obstetrician says this, and then the neonatologist tomorrow says otherwise, then the mother won't know I don't know what to do because one doctor tell me this and the other one tell me the other story. And the pre-delivery plan should be made with the parents, not only for what we should do now, not only whether she should deliver by vaginal delivery or by Caesar, but even after the delivery, we must always find out, we must always counsel the parents, are they willing to look after a baby with severe neurodevelopmental disability? Counseling, I'm not going to go through it. We must look at the survival data, complication data, the effect of the mode of delivery, the effect on future pregnancy, how long is this baby going to stay in ICU, what intervention looks like, and the prognosis and the risk of being pregnant, and impact on the family for prolonged ICU stay and the pregnancy termination. This is just a summary of what I have already discussed about. And as we said, the plan of care should actually be to optimize survival, or is it to optimize survival, or is it to minimize suffering? And when we assess for resuscitation, it actually does not mean that we should resuscitate or we should defer resuscitation. We are only assessing at that point. And it doesn't mean that every possible intervention should be offered. We can defer some of the things as well based on our data that we have. When we have a mother that declines intervention, it doesn't mean that we should not offer any care. It only means that we must redirect the care to the comfort measure. Maybe we are not going to actively resuscitate, but we might give you CPAP. We are maybe not going to admit the baby in ICU, but we will give some oxygen. And then it's always a problem when it comes to CTG monitoring. So they advise that if you are going to do the CTG monitoring, then it should only be done if there was such agreement that, yes, the mother wants the baby to be resuscitated. If not, then there's no point of why we should do CTG monitoring. In most cases, the CTG is actually put on if people want to decide, are we going to deliver this baby by cesarean section or not? So it is linked to plans regarding cesarean delivery. I know that was a full plate. It was also a full plate for myself. But if there is one thing that I learned from preparing this talk, is that even though gestational age is not a perfect predictor of the outcome, it is an easy way to help draw the line. Therefore, it's very important that we actually date the pregnancy accurately, because it has such a great impact on the decision that we make for these very viable pregnancies. Thank you.
Thank you, Angela. That was an excellent presentation on a very difficult topic. With Johan Smith, I'll ask him to say a few words as well. Because I think for us, I want to know, often these things happen in the night. So if you have a patient, for instance, a patient with preeclampsia, half CTGs on their fetal distress, Johan goes in, or one of your colleagues, and they will receive this baby. So ask him just tell us what happens and what's the outcome, hopefully. So thank you, Johan. Thank you for coming.
I want to thank the speaker. I think you're quite brave. Issues you highlighted are what we all still grappling with. I thought my voice is low. Yeah, that's very microphone. And we don't have the answers. That typical scenario you just highlighted of the DCDA twins, or for that matter, singleton babies looking like that, all of us would have said, well, no chance of survival and maybe a demise within minutes. But that is where we, as a tertiary institution, with all our protocols, and we hope our acceptable approaches fall apart a bit, because what do you do with them? You can't predict how long they will survive. How long should they be be kept with the mom in the so-called KMC or on the skin of the mom and allow baby to die. If it's 5 minutes, 10 minutes, we've debated this before. There is, as far as I know, no cutoff point, and I stand to be corrected. The longer you wait, the more you contribute to a possible lower rate or probable lower rate of survival, and with that increased risk of further morbidity. So and you know it, in adult medicine they speak about the golden hour. We are talking about the golden minute, the first minute or 2 minutes of life in a newborn. I'm just trying to find my, oh, here it is. So time is of the absolute essence. And it is extremely difficult in our two-tier health system in South Africa to guide younger people as to, I need help. Where is the slide? Yeah, there it is, this one, but I just want to put it on. Oh, there.
Current slide.
Because we don't train the younger guys and obstetricians to manage infants less than 28 weeks properly, and that goes for the pediatricians as well. They go out of here, they are suddenly confronted with that scenario. Just some facts. Survival rates, and the speaker has already alluded to it, the 50-50 situation at 25 weeks. I also work in Panorama, and sort of a bit of an overview. The red is Tygerberg Hospital mortality for 24 to 26 weeks. The blue is the Panorama figure, and the Von, which the speaker also alluded to, the Vermont-Oxford network. So you see the two-tier health system, and she's already eloquently showed where the differences lie. It's basically resources and your ability to support these infants from the start. And that's why at Tygerberg, and these are our figures as well from the neonatal network, from my colleagues Liesel Lloyd and Sandy Allgate. When did we start with Von? 2016. So our data is available here. You see it there. Mortality 75%, less than 24 weeks. And then a rapid sort of step up beyond 25 weeks in terms of survival. But below 26 weeks, 63% will die. The issue is, and again, she's highlighted that as well, you need to have a protocol, because we have 120 doctors more or less in our department. You need to follow a protocol, otherwise it will be chaotic. So we advocate, in short, that all babies showing signs of life at the time of delivery, irrespective of the gestational age and birth weight, be properly stabilized, and that is CPAP basically, and then taken to G2, and where they will be stabilized to follow their natural course with or without our support, whatever that support may entail. Mostly will be, the closer you get to 500 gram, will be CPAP and a drip and warmth and so forth and comfort care. Whereas if the weight is slightly higher, getting to 700-800 grams, they will get surfactant. And then obviously all the other role players come into play, whether they had magnesium sulfate, steroids, and so forth. And once an infant survives up to, these are international figures for you to look at from Japan and Canada and so forth, and then I'm going to end off. So once an infant gets to day 4 or 5 of life and is still alive, the actuarial survival rate increases quite dramatically. Those that die quite early. So with minimal support, non-invasive treatment, we did improve the care of these babies. Unfortunately, this doesn't go for infants born at Paarl, just speaking about our own region, Worcester, or further away. and therefore your socioeconomic environment and region where you're born determine your ultimate survival as well. Whether that be fair or unfair, you can debate that, and you probably have amongst yourselves. But you see here at 25 weeks, oh dear, sorry. You like the song? For the old guys. So survival rates according to gestational age 25 to 26 weeks on average in first world countries. And remember the viability definition in Japan has been 22 weeks since 1992. And they have this kind of survival rates and figures. Thanks. That's me again.
Thank you very much, Prof. Smith. That was very good. So I think that this topic is just extremely difficult because you don't know what's going to happen. There's a third chance of, I think in a place like the Netherlands, they will facilitate the people. There's a third chance that the baby will survive. There's 1/3 chance that the baby might die, and there's 1/3 chance that the baby will survive, but then with severe disabilities. And then from the fetal side, from the baby's point, that is difficult. That David might be able to help with that, but I think usually from the baby will grow up, and we say that for quality of life, you must have reasonable happiness. Is very difficult. It's very wide, broad term, but you can narrow that down a bit, and you can say, what is the ability of that child to be loved and love? And I think for us, we all work, and we sometimes the work is difficult for us, but generally speaking, every person would like to have to make some kind of positive contribution to society, and they must have some self-worth. And that's so difficult to predict. So thank you very much for everybody. We will have 5 minutes for questions, and then you can stretch your legs, and then we will have the next speaker. Any comments or questions?
Yeah, I think this is a very important topic for the people who will leave this department and go to private, because very often people forget to look at the circumstances. I got called this week because they're about to deliver a baby at 24 weeks and 4 days because the mother has preeclampsia, although from a germal side she's completely stable. The baby's IGR weighs less than 500 grams, and the baby is known with a major ABSD and has very likely Down syndrome. And I think, what on earth are they thinking? Because even at that gestation, in a healthy, well-grown baby, the mortality is more than 50%. Now you're born with a major cyanotic cardiac lesion that needs surgery, which cannot be done on a 500 grammer. And people sell, in that case, a neonatologist said, oh yeah, give me the baby, I can deal with that. I mean, that is completely not honest information to the parents. Parents cannot make decisions if we deliberately misinform them because we are incapable of actually answering the question. And therefore, I really like what she said. It's really about what is the outcome of this specific baby with everything that goes into that equation. It's not because you've managed one 24-weeker successfully that this one with IUGR and absent flow and an AVSD has any chance of survival. It doesn't. And the only honest thing you can do is be honest to the parents and not fall into that trap that somebody says, oh yeah, give me the baby, I can resuscitate that and keep it alive.
Thank you. That's very important. I had a quick look in terms of what you can find on the internet when you're in such a situation. And I think some of the networks, people are, when you're confronted with adversity or being trauma, the way that you think, it's very difficult because sometimes people will think, so what they will see is they will see the miracle babies, and it's my baby. When you're 26 weeks, the baby has a name, everybody is waiting for the baby. And it's very, very difficult. So I think, like you said, you have to individualize and you have to really try to get the message through. Because people often, they say that if we hope and we believe, then things will be fine. But often with that, it can't be fine. Any other comments?
Yeah, what we didn't mention is that, well, you did actually. Sorry, what's your name? Ronia. Ronia. Sorry, I referred to you as the speaker, my apologies. So Ronia has already refer to it. It's quite complex when you counsel, and that my sort of comment in the beginning that we don't train the young guys to look after these small infants in a way that in a first world country it will be done. And then secondly, they go out with that insufficient knowledge and start with this kind of practice, which is ethically unacceptable. The thing is also, when their weights are, and this Luke have taught us a long time ago, and it's also clear now postnatally, if your birth weight at a particular low gestational age goes to -1 standard deviation or -2 standard deviations below the expected, your risk of dying is extremely high, and when you do survive, your risk, I forgot to show it, and we found it in Panorama as well, your risk of coming out surviving with a major morbidity, cerebral palsy, cognitive severe problems is very high. So 5%, where we looked at earlier 10% percentile, they're now looking at 5% and third percentile. And when you reach those kind of levels, you have a very poor prognosis.
Thank you very much. You can, the next speaker will prepare and you can stretch your legs. Thank you for all the speakers.